group, together with Øystein and me, who are leading the clinical part. And we started with the least toxic drug. You know, rituximab is not only a cancer drug, it's an immune modulating drug used much in treating autoimmune diseases. It's a CD20 directed monoclonal antibody targeting B lymphocytes. We first published something in 2009. It was a case series of 3 patients who were given rituximab and had improvement of their ME. Then we did a small randomized 30-patient placebo-controlled trial, phase 2 trial, published in 2011, which also showed a positive result, although the main endpoint was not the right one because we thought the response would come earlier. So we didn't know enough about rituximab effects on ME at the time. Later we did a phase 2 trial with rituximab with maintenance because we found out that giving just 2 doses of rituximab could give a response, but it was preliminary. After some months, the symptoms came back. So we started doing also maintenance treatment. Mm. And also the other drug that we had seen from the patients coming to us with ME and cancer, it was cyclophosphamide. It's an inexpensive alkylating agent, which we know for decades in oncology and also used in autoimmune diseases. And we treated 40 patients with moderate to severe ME/CFS, not the mild ones, not the very severe ones. They were given a protocol that we had adopted from autoimmune diseases, 6 intravenous doses given at 4-week intervals. What we found in these patients was that the side effects were tougher than we usually saw in oncology patients. But there was very little hematological toxicity. And we were also concerned of the long-term consequences of cyclophosphamide treatments, especially in women, early menopause, infertility, and of course, secondary malignancy is also something an oncologist has to think of. But with the few doses these patients had got, we think that the chances were very small statistically. But if we got one such patient early in our trials, that would have been a catastrophe for us. What we did see was that we had 55% of the patients had a response. Some of them had very good response. What we also saw was it seemed that the response was quite long-lasting, even though we didn't give any kind of additional treatment after 6 months. Then we went on to do a national multi-center randomized double-blind and placebo-controlled phase 3 study looking at rituximab against placebo. And this was to verify or refute if B-cell depletion had clinical benefits and how the kinetics of these were. 5 centers, some of them very inexperienced in this area, but we had to have these centers with us to get money from the government to do the trial. Also, we had to give a lower dose for maintenance than we originally wanted to. We had to give 500 milligrams. You know, rituximab is quite an expensive drug. It was given as a maintenance at 3, 6, 9, and 12 months. And we observed these patients for 24 months. We also, for the 40 patients we treated in Bergen, we did endothelial function tests, cardiopulmonary tests, and gastrointestinal function tests, which also resulted in some publications. But, as you all know, the rituximab study was negative. We could not find that rituximab changed the course of the disease. You see the red and the blue lines are, you can just put them on top of each other. This was a good performed study, and it's very seldom that you get a negative study in the Annals of Internal Medicine. That means that they acknowledged that it was well done, but nevertheless, the result was negative. And why was the result negative? We can't really say, but there are many possible reasons. The endpoints were not the best. We had maybe too many patients with mild disease with the symptoms going up and down during the course of 24 months, which could give us, for example, some seemingly responders who are not actual responders. But I think in the end, in that setting, rituximab didn't work sufficiently well. I think that is the main conclusion. So we have to conclude that outside of clinical trials, we should not use rituximab for treating our patients. We haven't done that. Nevertheless, we really know that there is a subgroup that does respond, both in our hands and other investigators' hands. But this subgroup, used in the way we used rituximab here, is not big enough to be disclosed in a placebo-controlled trial. What we have seen in all patients treated with rituximab, nearly all patients, is that when we give the drug, we get an effect, but it lasts for some time and it declines. This is well compatible with, for example, autoantibodies being pressed down and being made again when the effect of rituximab is out. If we put together some of the clinical trials we have done, we see, in the same diagram, here we see the SF36. Most patients in the start had around 35 in mean SF36. And during the treatment, the patients had an increase. Also, we see in the rituximab study, which is here, the two arms, they also had somewhat improvement. What does this mean? Well, maybe just being in a clinical study can help patients to feel better. I don't know. But the study that had the best effects is the KTS2 study, which we see at the top here. And that was a study where we let patients have a maintenance treatment up to 2 years. Some of the patients had that. Other patients had just a year's or a little over a year's treatment. And we at the time believed that autoimmunity is behind ME, CFF. And we also believe that autoantibodies play a major role, as we also have heard many indications of in yesterday's presentations. We think that the long-lived plasma cells are a big part of this problem, just as they are in some autoimmune diseases that are resistant to conventional immunomodulatory treatment. If we look at the development of the B cell, the CD20 is on the membrane from the pre-B cell level and up to the plasmablast. We also find CD20 in some short-lived plasma cells, and also up to 20% of the long-lived plasma cells still have some remnants of the CD20 on their membrane. That means they can be affected by CD20 targeted monoclonal antibodies. The cyclophosphamide probably has its action in the area from the plasmablast and up to the plasma cell. What do we really think happens when we give rituximab? Well, we think that the antibodies go down. We have measured that. And it's the CD20 positive plasma cells that produces that we can affect by rituximab. But we saw the KTS2 study that when giving rituximab for a longer period, we got a better effect. And probably that has to do with recruitment of new B cells into the long-lived plasma cell pool. Cyclophosphamide probably acts by inhibiting the course of the activated B cells into becoming antibody-producing plasmablasts. In addition, cyclophosphamide has a general effect on all proliferating cells in the immune system and in other tissues. What does that mean? Oh no. One thing that we have nearly nothing of in the literature on ME is what happens after drug treatment, after the treatment period is over. There's nearly nothing in the literature on that. So we did a survey of patients 6 years after start of treatment in the cyclo-me study and the rituximab study. What happened to them? And we found that 18% of the cyclo patients, they had a performance, SF36 performance status in the normal range. That is in the healthy range. And 44%, they had a SF36 performance status of over 70, which is much better. It's the double of what they had when we started the treatment. So what does this tell us? Well, maybe there's some kind of a resetting going on after this kind of a treatment, if you get an effect. And we see that quite regularly also in patients that have had an effect on rituximab, that they don't end up at the same level that they started. They maybe have 10, 20 points above what they had at the start. So something has happened to the patients, also in the long run. And what about these long-lived plasma cells? They are the main producers of antibodies in our bodies. They, for example, are the ones that after vaccinations reside in privileged sites in the bone marrow and the gut walls. They can live for decades. Sometimes they can live there lifelong. They're very dependent on their surroundings and surrounding cells that give them this privileged site to be in. And they are to some degree also protected from drugs, which makes them maybe more resistant than many other immune cells. But what if these long-lived plasma cells start producing a defect or faulty autoantibody? Or if the signal to stop making a normal, functional autoantibody that has a role in the stoppage of infectious processes, if that signal is not given or that signal is not received by these cells, could that keep the cells producing the wrong autoantibody for long periods? Think of it, ME can be lifelong lasting. What is the reason? Well, this could be a reason. If these cells that have a definitive role where they lie producing all the time about 2,000 molecules per second, sending it out to the bloodstream. If that is going on for year after year, that can be a reason for the symptoms we have. But the good thing is that the long-lived plasma cells also can be targeted by drugs. And we'll hear about that in the next talk by Professor Fluge. My last slide. Things that we have observed that could be of interest for you. We have seen in all the 3 drugs we have treated with that the patients don't just get better in 1 or 2 or 3 symptoms, but all the symptoms they have, they change to different degrees. But nevertheless, it seems that we are targeting something central in the process that affects all the symptoms. And we, because of what we've seen, we believe that the key to treat the root of the disease is found in the immune system. The 3 drugs we've used, they have different kinetics in how they work. Rituximab, typically the patients have their response between 4 and 9 months. They start to have the response then. They can have it for different periods depending on the maintenance treatment that is given. Cyclophosphamide is a bit more variable because the patients have acute side effects that can last the 6 months they are getting treatment. It's hard to say when they're getting sufficiently good to have a response. And we can hear from Fluge on targeting the plasma cells. They have their own kinetics in when we see effects. We believe that what we have observed, both in the clinical situation and when they respond to treatment, that major signaling dysfunction probably is the clue to what is going on. And probably this is not only new autoantibodies, but it can be existing functional anti. And Yes, I'm finished. The circulatory system, the nervous system, GI, GU, and respiratory system are all involved in this disease. And we think of them as separate things, but in fact, everything works together. It's interconnected. And lastly, immune drugs work at different levels from where the symptoms are made. And we all have different adaptive immune systems. We're all different from each other. So we cannot expect every patient to respond in the same way, as the symptoms are created many steps from where we give our drug. And lastly, just a question. When we see what we have seen, my question is, where is the pharmaceutical industry? Where is it?
Olav, I see that you are more stubborn than my wife. You didn't respond to my clinging. So we don't have the time to refer to the question. And your boss is sitting on my right side, and maybe he will refer to the side effects and discuss. This is Professor Fluge from Norway, who will discuss attacking most probably the long-lasting plasma cells. Please.
Yes, thank you. So thank you for the invitation, Carmen. Thank you for the invitation. I'm going to talk about plasma cell targeting using the anti-CD38 antibody daratumumab in ME/CFS. So Olav has been taking us through the history, where we have the different clinical trials that we have performed since 2008, starting and until now. And I will focus on, so we have targeted the B cells. We have tried to target possibly the transition to plasmablast by cyclophosphamide, although that's a drug that can work on many subsets of lymphocytes. But now we are concentrating on the anti-CD38 antibody, which is present in high levels on long-lived plasma cells and also on plasmablasts. And these are mainly negative for CD20, although there is some expression. So daratumumab is a drug antibody that binds to CD38 on the surface of the plasma cell and gives a transient plasma cell depletion aided by the NK cell with the antibody-dependent cellular cytotoxicity mechanism. So the aim of this study is to get a transient plasma cell depletion with reductions of both the protective antibodies and possibly autoantibodies. So we know that functional autoantibodies after infections can disturb biological systems, and we have seen in some recent publications that you have multiple autoantibodies to many extracellular molecules, for instance, in otherwise healthy after a COVID-19 infection, and also been seen in EBV infections. So we think that the pattern of these functional autoantibodies occur possibly in otherwise healthy after infection as part of a normal immune response. And these should be usually transient and subside, but I think that some of these may persist in ME/CFS. So there's like an autoimmune component. It's not like in the classic established autoimmune diseases, but there are some resemblances. And we think that these disturb the regulation of blood flow on exertion, but also other biological systems. So this is the daratumumab pilot trial with 10 patients. It binds to CD38, reduces plasma cells with the purpose of reducing immunoglobulins. Inclusion criteria are the Canadian consensus criteria, moderate to severe disease, not the mild, as Olav described, and not the very severe, at least 2 years disease duration, and a defined onset, often after an immunological trigger like an infection, 18 to 65 years. And we had a run-in period for 3 months before starting intervention, with recording of questionnaires and Fitbit activity watch to register steps per 24 hours and resting heart rate and so on, to get the clear overview of the baseline situation not just 1 point, but over 3 months. And we used these questionnaires, the SF36, which has a scale from 0 to 100, and also the DePaul questionnaires short form with a scale from 0 to 112. What about the intervention? The first 6 patients received 4 daratumumab injections 2 weeks apart. And this is based on, we had really been thinking about using daratumumab since 2016, but we didn't want to do it until we had some data from case series in refractory autoimmune diseases. But that started appearing around 2020, when you had case series of lupus, dermatomyositis, several autoimmune diseases that were refractory to other treatments, but had effect from daratumumab. And in these studies, the range of dosing was very wide, from 1 to 24 injections with a mean of 4 doses, so we ended on that. The next 4 patients received the same 4 injections, but followed then by 3 additional injections, so they had in total 7. So the aim of such a pilot study is to investigate feasibility and tolerability, to see if this can be used. And we had only mild side effects, only CTC AE grade 1 to 2, and no serious adverse events. So the tolerability was indeed very good. No hospitalizations, no unexpected side effects. But the possible toxicity is allergic reactions, injection, this is given subcutaneously on the abdomen. You can have injection-related reactions. If you give too much, you can have low levels of immunoglobulins, hypogammaglobulinemia, and sometimes neutropenia, but that's mainly seen in patients who get chemotherapy at the same time, because this is a drug that's licensed for multiple myeloma and for amyloidosis, but it's starting to be used in refractory autoimmune diseases, but it's not indicated for that. So this is the baseline characteristics. You can see that the mean age was 38 years, and you can also see that 6 of these 10 patients were assessed as clinical improvement responders, and 4 had no significant response. This is the age, which 38 years in mean. You can see that they had a relatively high symptom level with the SF36 at baseline of 26, and a relatively high. The scale for DSQ-SF is opposite than for SF36, but they had a relatively high symptom burden. And you can also see that, oh shit, how do you put it back? Can you put it back? Yeah. The main disease duration was 12 years, and it spanned from 3 to 35 years. And we think it's very encouraging that also the patient that's been ill for 35 years was a major responder. So that's good. The mean steps in the baseline situation was around 3,000 steps per 24 hours. So this is the main result for all the 10 patients pooled together. This is the time on the x-axis and SF36 physical function, which has a scale from 0 to 100. And you can see that they started at 26, I think. And what is interesting, and you will see when the next slide, they respond much earlier than the rituximab patients. They respond from 6 to 8 weeks. Those 6 of these 10 patients that responded had a relatively homogeneous pattern, starting 6-7 weeks after the first injection. That's and they reach up to 60 approximately in mean. If we divide this by the responders and the non-responders, you can see that 4 patients had absolutely no effect on the disease symptoms. It's also indicated if they received 4 or 7 daratumumab, but you can see the responders, they are in the normal range towards end of study. both for those given only 4 injections and also those given 7 injections. So over more than approximately 90 in mean for that group here. And for all the responders, it's more than 80 in the mean, SF36 towards end of study. So these are the individual curves for each patient. Each patient has one color. And there you also see one patient with a very severe disease that was completely bedridden. The brown line didn't have any effect at all. As you will see, she only reduced her immunoglobulin level by 20%, as opposed to the responders that reduced to 56% in immunoglobulin level. So it's not so efficient immunoglobulin reduction in that patient. But I'll show you the pooled data for that. You can see that compared to the rituximab trial, it's relatively homogeneous pattern when they start improving. Very similar data for DSQ-SF. It's almost identical, except it's the other way around. Improving is lower value. So these are the steps per 24 hours from baseline and through follow-up. And the non-responders in red, no effect. The blue ones are the 6 responders, approximately 8,000 in mean towards end of study. And here are the individual data. But for the 6 patients with clinical improvement, all these had single weeks in this period with more than 10,000 steps per day, and individual days with more than 15,000 per day. So I think the objective measurement of activity supports their self-recorded questionnaires that they really had an effect of the disease, I think. So these are the serum immunoglobulin levels. You can see these are the pooled data, but you can also see the responders, the blue from the non-responders, have a more efficient immunoglobulin G, IgG reduction. And you can also see there's some heterogeneous pattern for when they recover their immunoglobulins. All patients recovered immunoglobulins towards end of study. So there's a 56% relative reduction from baseline in the responders and 40% in those with no improvement. I guess I have 6 minutes more. Yeah. These are the NK cells, and this is something that we have been thinking could be important. The NK cells have moderate levels of CD38, while the plasma cells have abundant with CD38 on their surface. So you have a transient moderate NK cell depletion from daratumumab treatment. You can see the curves. And note here the difference at baseline between the non-responders in red and the responders in blue in the baseline NK cell number. The stipple line is the lower normal range in Norway. The upper range is 533. So here are the individual data. You see that all patients recover their NK cells towards the end of study. So then I think this is an association that we are not quite sure if this is a true biological phenomenon or if it's coincidental due to the very low number of patients, 10 patients. All the non-responders in this study, this is on the y-axis, the NK cells number at baseline before intervention. This is the maximum difference of SF36 physical function from baseline. So the change during the study as a sign of clinical response. And you can see that all the the non-responders had low NK cell values at baseline. All the responders had higher levels of values. That could perhaps translate into a more efficient NK cell mediated cell killing of the plasma cells. But it can also be coincidental because it's a low number of patients. So 6 patients had a clinically relevant improvement. One patient, the green line, had a transient response and relapsed towards end of study. And you can see that the green one, she has a relatively early recovering of serum IgG. So maybe that could be something. In 5 of these 6 patients, it was sustained until end of follow-up. And these had SF36 within a normal population range in the last part of the study. And some of them has been now observed for almost 3 years. And after end of study, after 2 years, 1 patient is still in complete remission. 1 had a partial relapse, the blue line, from 26 months after first injection. And she is now retreated with a reduced dosing schedule. So out of the 6 responders, 3 or maybe 4 are still in remission, while 2, maybe 3 have a partial relapse. So after 2 to 3 years. So the pathomechanism, I will end in 2 minutes. CD38 is highly expressed on plasmablasts and long-lived plasma cells, moderately expressed on NK cells, with lower expression on different subsets of other immune cells, for instance, the transitory B cells. So we cannot be absolutely sure about the mechanism because different mechanisms are possible. But I think that the observed data support a role for functional autoantibodies in the maintenance of symptoms, at least in a subgroup of patients. So I think we are doing, because we touch the producers of antibodies, the plasma cells, we get the resetting. Like we take them down, maybe the balance in these functional autoantibodies will be different when they regrow and repopulate, like a control alt-delete. If anything else fails, try on the PC. So this is a small pilot study. The aim was to investigate feasibility. Can you take it back once, please? Feasibility, and we should assess the clinical effects with great caution. And no conclusions should be made before we have seen the double-blind and randomized study. And we have applied, and we hope to get this approved within this month. And this will be a phase 2 randomized, double-blind, placebo-controlled trial. Daratumumab versus placebo, and placebo is 15 milliliters of saline with added hyaluronidase, which is an enzyme that is present in the daratumumab to facilitate the absorption, subcutaneous on the abdomen. Criteria will be CCC, moderate to severe, at least 2 years duration, and because we're not sure about this NK cell, we will include patients with NK cells above 125 million per liter, 66 patients. I won't go through, but this is the study outline. I think that's it. Haukeland University Hospital has applied for a patent for plasma cell depletion. We have funding from the Norwegian ME Association. This influencer, Sarah Emilie Tandberg, who has a company, Careless, she's been an important funder. And we have several private donors and collections from patients, but we have no public funding for this study. And the industry has not supported anything. So it's costly. So at least the randomized trial will be expensive, but it will be, we're just starting, hoping that it will be okay. So this is the group. Thank you.
Thank you very much for the, so to speak, impressive results. There is another disease which may remind ME, and this is lupus erythematosus, which most probably is induced by EB virus and hyperstimulation of the immune system, cytotoxic storm, etc. a panoply of autoantibody, more than 180 different autoantibodies. And in Charité, next door, there was a group of rheumatologists who concentrated on the long-lasting plasma cells. And by and large, they didn't make a breakthrough. So it didn't enter into the armamentarium to fight lupus. They actually failed, except of bone marrow transplantation, etc. Should we not learn from their experience in lupus?
So we have read a lot of case series, not a lot, but those that are present on the use of daratumumab. And there's also lupus patients in those case series. And there are refractory encephalitis and dermatomyositis and other autoimmune diseases that were refractory to both rituximab and cyclophosphamide and mycophenolate and cyclosporine. And in these series that I've seen, it's working in many patients, but no, of course not all. And it has been, there was a review article pooling all these together, 80 patients given daratumumab for different autoimmune diseases, and the response rate overall in all these pooled case series was, I think it was 83%, and the toxicity was okay. These are very sick patients, many of them, and the number of injections used was in median 4, but it spanned from 1 to 24. So it's the dosing regimen or so is not obvious, but I have seen also case series with lupus patients that have responded, but I don't know that study from Charité, so I cannot comment more on that.
Gabriela, would you like to comment on the anti-plasma, a long-lasting plasma cell in lupus?
Yes, I think so far that is a dream with the reset. But what we see from autoimmune diseases now are those CAR T cells, which are in autoimmunity, which has really saved lives. In lupus, we have now completely normal people which were heavily sick before, and that could be also a proof of concept. But I found your data very stimulating, but it shows that not one size fits for all. And you need individual therapies, and you always see, and you have an immunological basis of your findings that if it comes back, and probably that would not be, we cannot expect a complete solution because we have an ongoing, I would say, autoimmune disease, and we have continuously treat the patient in some way. In CAR T cells, it is so that you have one shot. But of course then, and that could be because this is a very deep B cell depletion in the tissues, which we have much more as, for example, for rituximab. But everything what you showed learned us that it is an autoimmune disease which we have to target.
I know that there's a company in US that are thinking about maybe developing CAR T cells for this indication. We've used CAR T cells for lymphoma patients. I work with that in Bergen, and I think that at least presently it's we can see some nasty side effects, even though it's so I don't think it's wise to use that on ME/CFS patients at least the first years, because you can have a lot of trouble with even though it's very efficient and we cure half of the refractory lymphoma patients almost. So I wouldn't go for that at this moment. Maybe in 5 years when it's safer and you have better constructs and so on.
Yeah, we learn it in autoimmune diseases, in Sjögren's, and in also systemic sclerosis, how this works. But what we see in autoimmune diseases is different from lymphoma patients, that we have very low-grade side effects in comparison to oncology patients.
So that, of course, that's maybe the future. I think so.
So we have a positive angle to the future.
Yes.
Thank you. You can join me, please.
Thank you.
And while you are joining me, I will call for Judith Bellman-Strobel from Charité to refer to another study of B-cell depletion. Please.
Thank you very much, and good morning from my side. Thank you to Carmen and to the MS Research Foundation for this excellent conference, and I'm very happy to speak to you. So now I have to get organized with my pointer, but I guess I manage. So this is, no, I don't. That's it. So this is my conflict of interests. And here I brought you a slide pointing to the mechanisms of disease of long post-COVID and also of ME/CSF, as you learned. And we learned yesterday and in addition today how much antibody diseases or the antibody and autoimmunity is a pathophysiological mechanism in this disease. We heard from Birgit Sawicki the complex interaction of B and T cells, and we also learned about the role of autoantibodies, but we still have a lot to learn. But this situation, more or less, reminds me of two diseases I'm familiar with in my daily practice as a clinical neuroimmunologist. This is multiple sclerosis and neuromyelitis optica spectrum disease. And when you look at the cartoons, you find all those cells or cartoons again of B cells, T cells, autoantibody. And multiple sclerosis is a disease that is described in the textbooks as a T-cell mediated disease. We learned in between that B cells play an important role in this disease, and one of the most efficient therapies in multiple sclerosis is B cell CD20 depletion. NMOSD is another neuroimmunological disease caused by the autoantibody of aquaporin 4 against aquaporin 4. It is a protein on the water channels of astrocytes and expressed in the central nervous system. And here we also have a very efficient therapy, in this case CD19 depleting therapy, that helps us to treat this disease. So with my clinical point of view, I'm convinced that B-cell depletion is the option for a causal therapy for ME/CSF, at least for the subgroup of proven autoimmunity. We heard about the inconsistent results of the rituximab trials, and to be honest, they do not discourage me from the use of modern therapeutic monoclonal antibodies in ME/CSF. CD19 has a broader depletion of B-cell subsets, we heard already this morning, and the modern CD20 antibodies do have better tolerability. Rituximab is a chimeric antibody which fuses mouse and human parts. The new antibodies are fully humanized and they do have stronger cytotoxicity. So these medications are supposed to have a greater efficiency than the rituximab that we know for a long time, and we can evaluate the tolerability well. the better, the higher efficacy of these modern monoclonal antibodies are also proven in data in NMOSD. Here you see data from the phase 3 trial of inebilizumab. And when you look at the green lines, those are the phases of the disease where before the trial, where the patient were treated with rituximab. NMOSD is a disease of recurrent attacks, and we measure disease treatment efficacy by reduction of attack frequency or even no further attacks. And you will look at the black bars, that is representative of the phases with inebilizumab treatment. You see there is hardly any further attack. So these data from the phase 3 trial was also replicated in real-world data and published recently. So this is really data to rely on. And we also have data on the higher efficiency of modern CD20 monoclonal antibodies in multiple sclerosis. Please concentrate on the lower part of the slide, where we have a closer look at the blood situation after applying rituximab versus ocrelizumab, which is one of those modern humanized CD20 antibodies. And when you have a close look, you can see this small pink bar representing B cells still after rituximab treatment, and there is no B cells to detect in the blood compartment and even in the CSF compartment after CD20 depletion. These data motivated us to set up a platform trial for proof of concept studies to test modern CD20 antibodies versus placebo and inebilizumab CD19 depletion versus placebo as a proof of concept for these two compounds. We plan to use a standard application with 2 treatment phases, 6 months apart. We have planned an additional 3-month follow-up, and the primary endpoint is SF36 physical function. You are familiar with already, as the colleagues from Bergen also use this primary endpoint. The inclusion criteria make sure that we deal with autoimmune post-infectious ME/CSF, and one of our main conditions is that those patients have to have a clinical response to immune absorption before inclusion in the clinical trial and independent of the clinical trial. So we really want to make sure we have autoimmune post-infectious ME/CSF. We already have first clinical experience with CD19 depletion in one of our patients that we care for together with the Fatigue Center at the Charité. This female patient was taking part in the immunoabsorption study of the Fatigue Center. You're going to hear more about it later on. And she responded well to immunoabsorption. And to explain the slide to you, the black lines is the SF36 physical function in the clinical trial of immunoabsorption. They received within the first 2 weeks 5 cycles of immunoabsorption and were followed up during the time. And whenever they worsened again, they had a second cycle of immunoabsorption following the same protocol. And this patient then received in April 24 2 doses, initial dosing of CD20 and CD19 depletion with inebilizumab. And you can see how the patient improved quite well within quite short time and remained stable for about a year and deteriorated afterwards, as we would expect when we do not have maintenance therapy. We had a second patient following the same approach. Here you can also see how the patient did after immunoabsorption, and this patient is very early in the phase of the disease, or the early phase of the therapy. So we are really eager to follow him up and see how he develops. Tolerability was very well. We had no problems with any side effects. So let me conclude. I think there is a strong rationale for B-cell depletion in post-infectious autoimmune ME/CSF. We should target modern anti-CD20 and CD19 monoclonal antibody therapy as it is of high efficiency and well tolerability. We have promising results of individual treatment attempts, and we hope to get our clinical trial running very soon. We are waiting for the answer of our application for a grant. Just to give you numbers, it is a 5 million grant we applied for, and keep your fingers crossed that we get a positive answer.
Is there any questions? I was wondering a little bit about you had immune absorption first, so then it's maybe difficult to assess how much the IgG levels will be reduced due to the CD19 antibody treatment. But do you have any figures for that, whether you recovered in IgG before you started?
They are recovered because this was well apart. So this is about a year or more that we had the immunoabsorption intervention and when we started the CD19 depletion. We, in NMOSD, we have several patients on CD19 depletion therapy, and there is very few that do have falling IgG levels, but we do not see that on a regular basis.
Question?
Yeah. When you have patients with decreased IgG levels, do you have an increased rate of infections or complications in these patients, or?
We monitor those patients closely. We see them every 3 months, and we monitor the IgG level and also any lab results that could hint to infections. They do not report more infections. Sometimes it takes a little bit longer to get rid of the infection. And those patients that are those few patients that have pathological low IgG levels and have report serious infections, they receive immunoglobulins in addition, and then we can control the situation.
That was the second question, yes.
The last question over there, maybe also, yeah.
Can you hear me? Yeah, okay. You pointed out this modern monoclonals which has been humanized compared to chimeric and earlier treatment. I think maybe this is an important point because as long as you treat with immunoglobulins which are not homologous, then you also induce an immune stimulation on top on an immune suppression. And then you really don't know what's going on. So this using humanized antibody might be a very important point.
Last question over there.
The patients who respond to CD20 treatment, are these those who have an EBV trigger of their disease, or is there any difference between the trigger because B cells form the reservoir of EBV?
Those two patients I displayed here had CD19 depletion. We have a few patients that have the comorbidity of multiple sclerosis and ME/CSF, and some of them are treated on the basis of multiple sclerosis with CD20 depletion. And to be honest, we have not checked on their EBV status, but to extrapolate as they have a secure diagnosis of multiple sclerosis, EBV definitely should play a role in these patients.
I can add that in our previous CD20 targeted in the trials, although EBV has been maybe most common trigger, we have seen responses both among EBV triggered and other infections. So I think we move on. Thank you very much to the next speaker. And this is Dr. Sato from Japan. Thank you.
Good morning, everybody. It's a great honor to be here, and thank you for inviting me in this such great conference. And we have just started our risk study in Japan, following the Norwegian studies and Germany study. And okay, green, sorry. So a Japanese pharmaceutical company, Zenyaku Kogyo, supported this study. And just let me introduce my background. I'm a neuroimmunologist, and similar to Dr. Strobel, I see a lot of MS and NMO patient, and from this experience, we would like to conduct a risk study in Japan. This is a first such immunotherapy-related treatment for MSCS patient in Japan. So in this sense, it's very precious. So you don't have to listen to this all of these, but red color studies is by us. So we show that there is a link between autoantibodies and brain abnormalities, and also we show that there is a skewed B cell receptor repertoire. And your Norwegian riskmap studies is very help us to start. They show there are responders. That's very important. So we learn much about your study. And the title of the study is an exploratory placebo-controlled double-blind phase study to evaluate the efficacy and safety of riskmap in ME/CFS. Exploratory is an important point for us. So that this is a physician-initiated single-center study, and the number of patients is 30, and these patients are randomized into riskmap first group and placebo first group. And the doses of the riskmap is 375 milligram per square weekly for 4 times. This is a standard regimen for various autoimmune diseases. So after 24 weeks, these 2 groups switched each other, and we will look at the biomarkers and the clinical efficacy. So for the selection of patient, this is a first trial, so we try to select a typical patient, but not restrictive to specific population. And also well characterized, which means we recruited from our own clinic. And the selection criteria, so very simple, just adults with meeting Canadian consensus criteria. And performance status is like Bell score, Japanese version of ADL score, and the moderate to severe patient is included. And exclusion criteria is also not so complicated, just excluded concomitant autoimmune diseases or immunosuppressive drugs are taken. Some patients who started a new alternative medicine or severe depressed patient. And prohibited concomitant medicines also includes immunotherapy or new alternative medicine, etc. And for the endpoints, we have a primary and secondary, and the secondary endpoint include clinical evaluations as well as biomarker study. So the primary endpoint is a proportion of patients with an improvement of performance status more than 1 at 24 weeks. So very simple, just ADL assessment is a primary endpoint. But as we prepare adjustment factors, which is PS score, moderate or severe, or prior infectious onset episode, positive and negative, and anti-beta adrenergic receptor antibody, positive and negative. Secondary endpoints includes, so in addition to the fatigue score, which is a primary endpoint in Norwegian listener study, we set up a system to evaluate daily percent spine position, sitting position, or upright activity, etc. by smartphone input. And also we collected data on post-exercise malaise record as a QOL score, SF36, Compass 31, etc. and hand grips as well. And for the biomarkers, so this is an exploratory study. So we evaluate this. This is very important. Include gut microbiome, brain imaging, include MRI and SPECT, which shows a brain circulation, and immune biomarkers as well as metabolome in the blood. And immune biomarkers include anti-beta 1, beta 2, M3, M4 autoantibody titers, comprehensive immune cell subset analysis by flow cytometry, and specific B cell group, which defined by the immunoglobulin heavy chain V330, which is assessed by qPCR. Because in our B cell repertoire analysis, we assume that this specific B cell population is interesting because the frequency of this population was upregulated in infectious onset patient, and beta adrenergic receptor positive patient, etc. Others include just standard practice in this trial, including safety profile, etc. So that's all. This is acknowledgement. So the strong leadership by Professor Yamamura realized this rhythm study. Then also Dr. Okamoto is a neurologist who is a principal investigator of this trial. Thank you very much for your attention.
We have time for one or two questions. I have one advice regarding the primary endpoint. I would change the fatigue score that we used in the first trials. It's not so very good because of recall bias and because in that they should compare their clinical state as compared to baseline, but they forget after half a year or 1 year. So I think you should rather use FF36 or one or the other, but that is just an advice from us because we skipped that.
Thank you.
Any other questions? Carmen?
If we give advices, I would include only patients after infection-triggered onset.
Thank you.
So thank you so much. Then we will hear about immunoabsorption in ME/CFS from Dr. Elisa Stein. Please.
Yeah, good morning, everyone. I'm happy to talk about the efficacy of repeated immunoabsorption in post-COVID ME/CFS. I think most of you have seen most of the data already because it was published last year and we talked about it in several conferences already. Nevertheless, it's the basis for further studies that we are conducting, so I'll sum up quickly, and I hope the green one, okay. This was an intelligence test. So we've heard a lot about the G-protein coupled receptor autoantibodies, and in pre-pandemic times, we already found that they are natural regulatory autoantibodies. We picked the beta-2 adrenergic receptor autoantibody and we saw an impaired function in ME/CFS. We saw also elevated levels and a correlation of elevated beta-2 adrenergic receptor antibody levels with symptom severity in ME/CFS. This was already mentioned in several talks before. And we observed in clinical trials targeting autoantibodies that they provide an evidence in efficacy in ME/CFS. So these are the two trials conducted in 2018 and 2020, where we applied immune absorption on patients with ME/CFS, and we saw an effect. So based on these findings in pre-pandemic times, and also based on the findings and studies in post-COVID and autoimmunity, we conducted this observational study on immune absorption in post-COVID ME/CFS. We picked 20 patients with post-COVID ME/CFS, fulfilling the Canadian criteria, and elevated beta-2 antibody levels. Out of these 20 patients, we had 13 female and 7 male patients. The age was in median 40 years and the duration of illness 22 months. Bell score was between 30 and 40. And we conducted 5 sessions of immune absorption within 10 days in an outpatient setting. And responders received a second cycle after worsening of symptoms, which was in between 6 and 10 months, roughly. The primary endpoint was the improvement of at least 10 points in the short form 36 physical function 4 weeks after immune absorption. We also applied further surveys, the COMPASS, the FSS, Bell Scala, the PEM Scala, and we measured the hand grip strength and the endopet. So here in the slides above, you see the curves of immune globulins, and we could see a significant reduction in IgG, IgM, and IgA after 4 weeks after the immune absorption, and then in the course they normalized again. And in the slides lower, you see the curves of the autoantibody levels. So in all 4 autoantibodies that we measured, the beta-1, beta-2 adrenergic receptor antibody, and the muscarinic, the M3 and M4. So you see 4 weeks after the immune absorption, you see a significant lowering, and then after a normalization. And there, in the talk before, for Judith Berman-Strobel, there was the question of how you know that the IgG levels were not affected by the immune absorption. And here you see that they will normalize again. And then after normalization, you will apply further medication. Here you see the course of symptoms. So we see an improvement in SF60. SF36 after immune absorption, and a little bit lowering after 6 months. In the responders, this is more obvious, of course, and in the non-responders, you didn't see this significant improvement. Then we pick further symptoms. For example, in the PEM, you also see an improvement of PEM after 4 weeks, a worsening then in the following month. And in the pain score, for example, also we could see this significant improvement. And here in the slides on the left side, you see the first cycle, so the improvement and the worsening after month 6. And on the right side, you see the second cycle. So again, we have an improvement after the immune absorption, very clear after 4 weeks. And then in the course of 12-month follow-up, we didn't see a long-lasting effect. So the conclusion is that we see immune absorption, and hereby lowering of the autoantibodies, is effective in patients with post-COVID fulfilling ME/CFS criteria and elevated beta-2 adrenergic autoantibodies. But we also see that there is no long-lasting effect of repeated immune absorption. This leads us to the question, what is the role of immune absorption in further treatment of ME/CFS? Herefore, we are still waiting for the results of a RCT, which is currently taking place in Berlin in the Department of Neurology of Harald Prüss. But we know already there's limited availability and limited efficacy, so this will not be the only possible treatment for ME/CFS. But what we already heard from Judith Berman-Strobel, that in combination with CD19 or CD20 monoclonal antibodies, depleting the autoantibody producing B cells, there might be hope for a long-lasting effect and treatment. And last but not least, we are still looking for causes why some people responded and some people were non-responders, and therefore the B-cell subtyping, where Birgit Sawicki told us yesterday, or showed us yesterday, the super interesting results, there might be one reason for responding versus non-responding. Also, we are measuring further autoantibodies and further markers for immune dysregulation. So all of this wouldn't have been possible without the amazing team of the Institute for Immunology of the Charité. Thank you very much.
Thank you very much, Elisa. Professor Scheinenborgen asked us to see if there are interesting questions from the public. There are many, and most probably they will be taken care of on the website, etc. But there is one note here that I would like to read it, and you to respond to her and to other patients. And it is, I'm really unhappy always healthy positive results of the immunoabsorption. I crashed to Bell 0 afterwards and know a whole of fellow patients whom happened the same. You have to address it and to convince her to come for the therapy. Please.
No, but this is something we saw a lot, especially in patients with a low Bell score. That if there's a certain line, if you're below this line with your physical status or your physical function status, then the whole procedure of immunoabsorption is very, very exhausting. Like you go there, especially because we did it in an outpatient setting. So the people had to get there. Some of them had to use public transport. They had the whole, the people they didn't know, the atmosphere they didn't know, the whole procedure of the puncturing of the veins and so on, and then going back, then having 1 day at home, then going back there. So it's not the immune absorption itself that leads to a worsening or to a crash. It's the whole procedure around it. So this we have to have in mind, that with people with a very low, but we'll have another talk about immune absorption in severely ill patients. So what we saw is that up on a certain level of, let's call it fitness, this whole procedure is bearable. And we shouldn't be very careful, or we should be very careful of applying immune absorption in people who are patients that are not, that are below this line.
So can I add to your answer that nothing is 100% positive, and there